Thank you, Sheila, and good morning. I forgot my cowboy hat, but you'll excuse me. I really do want to welcome everybody here to the first CME event since I've been chair. I started that position 4 years ago. And the kinds of changes that we've seen in the department have been substantial and meaningful, and I want to express my sincere thanks to Sheila Brewington for leading this effort, and it's a really wonderful moment that I'm very proud of, and I'm very grateful. I also want to thank Von Pedrosa for his guidance and help in steering this to a great product. And it's important to point out some people who there's no way this could have happened without their help, and that would include Jill Pyle, Glenn Katz, Eric Birnbaum, John Guerin, and Lacey Matzler in particular. So a round of applause, because I think they've just done a fantastic job. So what I'd like to just extend our welcome to is to think about the UT extended physician network that we're building. We're all part of one family, and I'm proud that we can be partners in healthcare and, frankly, in moving the very best healthcare to our patients. The department that we are assembling at UT Southwestern and continue to build relies on the very latest technology and understanding of that technology, superb interpretations, great consultations, and I want to emphasize that word to everybody. We are your partners, we are your consultants. Rely on us. We want to help you. We want to steer you to the right scan all the time. I'd like to just give you some perspectives, at least my perspectives, as somebody who has been through academics, starting out at New York University, where that transition of innovation into patient care was paramount, and that has stuck with me through my entire career. That is a perspective that I'm proud of and that we are bringing to this institution. So when I got here 4 years ago, I wanted to push this mission forward, and you can read for yourself what our mission statement is. But the real important words here are world-class, translation of innovations, and notice that the prime motivator is to optimize patient outcomes. We're your partners, and we want the very best for our patients. So I want to start with this popular, at least in a radiologist's viewpoint, it's a very popular article that was published in Health Affairs. And there were several thousand internists who were interviewed, and they were asked to rank the most important innovations to their patients in medicine. And the results are here, and you can see there's lots of interesting things like cardiac enzymes, et cetera, but we appreciate that at the top of the list was MRI and CT scanning. That's not radiologists who rank this, this is internists. So we know the utility, at least in this particular, I would call it soft science approach, but also the impact and value of MRI and CT has been recognized by the Nobel Laureate Selection Committee, because the inventor of CT scanning, Hounsfield, as well as the two inventors credited with MRI, which are Lauterbur and Mansfield, are Nobel Laureate winners. So the thing is this has been a very, very important tool for us to take care of patients. Let me share with you one story. When I was a medical student at St. Vincent's in New York City, I was a third-year student, and we were in the emergency room. It was a big trauma center. Patient comes in, and they're polytrauma, and I remember we had this sort of mini surgical suite in the emergency room. And what happened is that the patient had a belly that they were concerned about. The radiology resident came running into the chief surgical resident and said, "Can I please do a CAT scan?" And the surgeon looked at him almost scornfully and said, "You can't slow this down. This man needs an exploratory laparotomy." And we know that the whole world has changed dramatically since then, because an exploratory laparotomy for any purpose, in particular for trauma, is rare because of the absolute value and unequivocal value of CT scanning. One other story before I go on. There was a trainee whose name was Stephen Katz. He was a pretty good guy, but he loved imaging, and he would totally overutilize CAT scanning. So his nickname for the radiologist was Stephen CAT-scan. So our big challenge is, everything's complicated. You know, when you take a look at PubMed, the volumes of information that are coming our way daily are extraordinary. We need to rely on each other to help us get through this information overload. That's what subspecialty focus is all about. For us to guide you to appropriate imaging, we need to be so facile with what's going on, and you don't always have the time to know all the features in this subspecialty. With the increasing pressure for cost containment, appropriate imaging is needed more than ever. But appropriate imaging is important because there are risks involved with certain imaging, so we want to minimize the risk and maximize the benefit to risk ratio. Here in the slide, it highlights some of the important aspects of what's happening in the cost arena, with 17% of the US GDP being attributed to medical costs, and imaging is a cost driver. Now, inappropriate imaging has been one of those cost drivers. So while we can show volumes and volumes, a couple of factors are involved there. One is, as we know, that the largest amount of imaging actually occurs in the self-referral arena. And in fact, I don't know if people know this, but the actual largest volume of imaging done of all imaging modalities is echocardiography. Now, there can be very good utilizations of echo, but there are sometimes inappropriate utilizations for reasons that go beyond what the patient definitely needs. We are here also to look at, okay, what is appropriate imaging based on the complexity of the medical condition and the wide array of techniques that you can choose from. And we're here to help you improve your way to get to the most appropriate imaging so you get the best answer, to manage the patient the best, so we get the best outcomes for our patients. Here's some information focusing on neuroradiology imaging studies here, and you can see head CTs, you can see spine CTs, you can see head MRs, but the winner in terms of utilization, and notice the steep rise, is in spine MR. And just recently I heard an advertisement for some spine center in Dallas where they were saying, come on in and we'll give you a free consult of your MRI, which means almost everyone's getting an MRI. Yet, if you look at this particular article, and I'll give you a reference, Jerry Jarvik has done a lot of work, there's a lot of unnecessary imaging going on. And it's unnecessary for our patients. And our radiologists also guilty of just saying, yeah, you tell me what to do and I'll do it. That's not a consultant, okay? We want to be your consultants. So low back pain is one of the terrible examples of care in which duplicative efforts, delays in actual definitive management, inefficiencies, poorly defined outcomes, and uncoordinated care have driven up healthcare costs extraordinarily without a lot of benefit. How many people have had patients with failed back surgery? Okay, so the problem is that so many conditions actually need to be managed conservatively. And Dr. Jarvik has several articles on this. He's a radiologist, and he is the staunchest advocate of appropriate imaging, and he doesn't believe that imaging should be the first test. In fact, he's got an algorithm that he proposes in which imaging is way, way down the line after several failed strategies. We want to help you through those kinds of algorithms. And here is just one slice from the American College of Radiology guidelines. This is low back pain, but if you take a look, this is variant 3. There's a ton of these variants. We can't all know these, at least all of you can't know these. It's our job to help guide you through this. In this variant, a patient with one or more of the following: suspicion of cancer, infection, and immunosuppression. Well, that's different than the patient with no underlying medical condition who presents with back pain. And there's a different algorithm. These algorithms were pooled mostly by radiologists with some input from relevant clinicians. So in here, we can see MRI lumbar spine without and with contrast was given the highest score. Of course, these will be nuanced depending on what the patient's risks are. So if somebody had renal insufficiency, we would then choose a different score for the particular patient to customize their experience for their condition. And again, we can help you through these algorithms to drive our patients towards the very best care so that we get the best outcomes. Now, this is being more and more instantiated in formal decision support. So I'll say that the consultation that we can provide will be informal, but we're working towards the formalized version in which when orders are placed, you can place an order and you can get pop-up menus that can help guide you through. That's not instantiated yet, but that's something to look forward to, and we'll look forward to working with you so that that will ease your pain and drive you to the right exam earlier. Now that doesn't mean that because we make it simple that we want to lose contact. One of my biggest complaints about the way my career has changed is the loss of contact with all of you. When I trained, there was a big ballroom and all the doctors would come down and we'd have great conversations about our patients, and I miss that. We're trying to work that back in through electronic contact. You know, the geographic spread has created tremendous challenges. But if we can work this in where I can pop up and see one of you in a little window, you can see me, and I can share the screen and point to the finding, and that way we can have a very quick, succinct consult. That's the future, and that's what we are driving towards, and you, as part of our network, will have access to that. So let's talk about value in imaging. Is a costly exam really responsible for costly care? And let me share with you a trip that would involve the consideration of a patient with right upper quadrant pain. You might start with an ultrasound. And what would happen if it was negative? You might go to a CT, and if that were negative, you might go to an MR. And so you would say, I'm starting with the ultrasound because it's the least expensive test. And what we need to help you understand and help us all understand is, when is it actually most appropriate to just start with the MR immediately? Because, for example, the sensitivity of ultrasound for common bile duct stones is 20%. If part of our management is going to involve the detection of a common bile duct stone, we may see the gallstones, and then if somebody comes in and says, well, I need to know for the further management, is there a common bile duct stone? The ultrasound is only going to hit that 20%. CT for common bile duct stones is about 40%. Sensitivity for MRCP is about 95%. So if that is involved, that we have to be thinking, like a chess game 3 steps down the line, that may, in certain circumstances, be the very best first test, so we can actually save cost by virtue of getting the right information at the right time, and importantly, the negative predictive value. So if they do not have common bile duct stones with MR, the negative predictive value is also above 90%. So you're in pretty good shape. And then, of course, imaging isn't going to answer everything. We need our clinical input to get to the right decision. So these kinds of decision supports guiding us to the right test can generate value. And can the right scan generate value when value is increasingly being defined as outcomes over the cost of care? So we need to be having in discussions with you, what are the outcomes that we can anticipate from a particular imaging strategy? Value focus, as you know, is coming. I just clipped this. This is from January 26, 2015. 24 leaders representing consumers. Here's Sylvia Burwell announced that measurable goals and a timeline to move Medicare program and healthcare system at large towards paying providers based on quality rather than quantity of care they give their patients. So the per-click way of practicing is going to be less and less prominent in our practices, and therefore it's not in our interest to order lots of exams, nobody's interest. As we try to capture more vigorous contracts for all of us, it's going to be the efficiency of care with the outcomes being emphasized, and we can all work together towards that end. So then I'll throw this at you. Is imaging a commodity? Is a CT scan here, a CT scan there, and a CT scan at the mom and pop outpatient clinic? And I'll place a strong opinion, it is not a commodity. What defines a commodity? A commodity has value, and I'll say, well, is value equal? Is the outcome over cost equal? No, it's not. Is it produced in large quantities by many different providers? That definition is surely fulfilled with imaging. And is it equivalent across providers? That is there uniform quality? An absolute no. I'm going to show you an example of that. Is there little differentiation across the supply base? No. There's a lot of differentiation. In considering a commodity, there's a hierarchical construct that you can consider. That is, the lowest level that we look at is technical performance successful? is diagnostic performance, diagnostic impact, therapeutic impact, health impact, and societal impact. And here Jerry Jarvik has formulated this in the construct of a lumbar spine example. Now, these are important points, but a lot of times people just quit at the technical performance. I can get an L spine. You know, guess what? I can call up this little mom and pop shop. I'm going to get it in 30 minutes. And half the time, the 30 minutes is basically, well, that's what they tell you, but the patient's waiting there for a few hours while they're waiting. That's just off your back. We're working towards getting your access as smooth as possible, but that's not the only criterion for what is value in imaging. So I want to give you an example for prostate cancer, which is my area of interest and expertise. It's very helpful for detecting cancer, particularly for men with a rising PSA and in the setting of repeat negative biopsies. UT Southwestern, we use a multiparametric MRI. That's a T2-weighted sequence, a diffusion-weighted sequence, a dynamic contrast-enhanced image. You don't have to worry. If you're ordering a prostate MRI, you just click prostate MRI and we're okay. We'll take care of the rest. And we will guarantee you the very best exam that can be done. We get referrals from all over the country to UT Southwestern, so we certainly can provide the very best care in Dallas. We use high-resolution technique to detect and stage. Some mom and pop shops use low-resolution techniques. They're very comfortable for the patient, and I'll address that in a moment. But they don't detect the cancer, and they can't stage it because the spatial resolution is insufficient. So the patient's in and out really quickly. They come out with a smile. They've got their Starbucks environment, and there's absolutely no answer for this patient who's struggling with why my PSA is elevated. So I want to show you this example. Here's two T2-weighted images of the prostate. One on the left, one on the right, and I know that you're not imagers, but you probably have an intuitive approach to which image you think is superior, has a higher quality. And we can see that the image that is sharper with better detail and better image contrast is one that has an endorectal coil, which is a little more uncomfortable for a patient. But it reveals far more detail and far more useful information. So if our job is to keep somebody satisfied as a customer, which we do want to do, or if our job is to keep them satisfied and give them the very best outcome for the dollars that are spent, we need to go to the best exam. And let me show you this one step further. These are diffusion-weighted images, 2 examples. Same patient, done in different fashions, and if I tell you that a bright spot on this type of image is going to represent cancer, I think you can all see the cancer there. And I'll just highlight that for you in a second. But the endorectal coil image clearly shows you the cancer, whereas the non-endorectal comfort coil approach fails to detect the cancer. So in this particular patient, we can guide a biopsy. Here at UT Southwestern, we fuse the MR and the ultrasound in our urology suite, so the urology and radiology departments work very closely together. We fuse those images together, and we wind up with a great result where we have shown an increased positive biopsy yield of significant cancers. We're not capturing those cancers that men can live with. We're capturing the cancers that will threaten their longevity. And this is a huge contribution through collaborations. This is a kind of great imaging and great outcomes for patients that we can extend across our enterprise. So acquisition protocols, interpretations, imaging's not a commodity. The results are not equivalent. And the inconvenient truth is that an endorectal coil far outperforms a non-endorectal coil. Is it more expensive? Does it require more resources? Yes. But does it have more value? Do we have the outcome over cost equation working in our favor? Yes. So what happens to the patient who's negative and the rising PSA keeps going, they get repeat biopsies from the urologist. I've seen patients with 6 rounds of negative biopsies. You wonder if there's any more prostate gland left after that. 6 rounds of negative biopsies and still not a definitive result. We just had this case a week ago. Dan Costa will talk to you later, and he will be showing examples just like that. And this patient, we directed them. The tumor was all the way anterior where they don't sample. We fused the MR and the ultrasound. The patient got a definitive result, and it was a Gleason 4+3. This is a bad cancer. So this patient just would have been cruising along, and it may have been to the point where it gets out of the capsule and metastasizes, and then longevity is just miserable. We were able to help that patient with excellent imaging. We provide this imaging in a very caring environment. We have a physician assistant who's expert at dealing with our patients. She will interview every single patient. We know that the endorectal coil has more anxiety than actually is the experience, but Debbie absolutely helps them along the way. So in closing, I'm very proud of our department, and I'm proud of the alliances that we have throughout the UT system, and I'm excited to bring more of this expertise to more of our patients so we can drive these initiatives towards the very best outcomes of patients. And I thank you for your attention.